we are live now, sir.
Good evening, everyone. I welcome you all for today's Journal Club meeting by Dr. Kundavi and Dr. Sindhuja, and I thank them for their Herculean efforts to make it a successful. And Kundavi, I really thank you for selecting today's topic, on Aphrodite criteria in the management of male infertility. Such an latest and interesting topic. I really thankful to you because it will be useful for all of us, in the management of male infertility. And I look forward to Dr.
Dr.
Nandita.
Mridubhashini's team, Dr. Geeta Radhakrishnan is an expert, sir.
Okay. Ma'am is not there. Dr. Mridubhashini is going to join us.
I'm not sure. Because she was busy with something. That's why she said I could take it up.
Sure. Dr. Geeta, we look forward to you. Yes.
Yeah.
Please go ahead and enlighten us on Aphrodite criteria. Okay. Thank you. Thank you so much. So we'll all will be awaiting to listen to you. Thank you.
Sindhu, introduce Dr. Geeta.
Sindhu ma'am, kindly unmute.
Yes. Good evening, everyone. Welcome to the TAPISAR Journal Club. It's a great pleasure to introduce our expert for today's both sessions, Dr. Geeta Radhakrishnan ma'am, who is the Deputy Clinical Director and Academic Coordinator at Women's Center and Hospital, Coimbatore, Tamil Nadu. She was formerly the Director, Professor and HOD of Department of Obs and Gynae at the University College of Medical Sciences and Guru Tegh Bahadur Hospital, Delhi. Ma'am has done her MBBS from Lady Hardinge Medical College, University of Delhi, and PG from PGI Chandigarh. Clinical and teaching experience of nearly 42 years. I understood ma'am is very, very senior when she told me she was one of the first few members of ISAR. It's a great pleasure to have you here, ma'am. I kindly request you to introduce the chairperson and the speaker for the first session.
Thank you, Sindhuja. The chairperson for the first session is Dr. Nandita Thakur. She's a medical director, Nandita Fertility and Research Center, Chennai. Academic head and coordinator and senior consultant, Mehta Hospital, Chennai. Her areas of interest is reproductive medicine, high-risk pregnancy, genetics in obs gynae, lifestyle and gynae disorders. Of course, she's been all these years immensely involved in teaching, and she has also undertaken a lot of focused training programs on skill training, workshops, and designing teaching modules. And she's presented many papers at national and international conferences. Welcome, Dr. Nandita, madam. It's nice to have you to chair this session.
Ma'am, I request Nandita ma'am to introduce the speaker. Okay.
Okay. Can you hear me?
Yes, ma'am, we can hear and see.
Okay. I would introduce Dr. Kalpana P., who has done her undergraduate from Kilpauk Medical College and her MS-OG from Thrissur Medical College and her DNB-OG batch of 2018. She has also done her fellowship in reproductive medicine at Women's Center by Motherhood. So we welcome you, Dr. Kalpana.
Good evening, ma'am, and respected teachers. I would like to share my screen. Shall I?
Yes, ma'am.
Okay. Shall I start, ma'am?
Yeah, Kalpana, I think we can get it going. Yeah.
Yeah, okay. Okay, so my journal club is on, my article is on Aphrodite criteria addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. It came in a Journal of Reproductive Biomedicine Online on 2024. The impact factor of the journal is 4. So it is a concept paper. So in this, the research question of this journal is, can a novel classification system of the infertile male Aphrodite stratify the different subgroups of male infertility to help the scientists to design the clinical trials on the hormonal treatment of male infertility, and clinicians to counsel and treat the endocrinological imbalances in men, and ultimately increases the chance of natural and assisted conception. Introduction. Male factor accounts for approximately half of the infertility cases. Wide range of non-mutually exclusive causes were there for male infertility. Therefore, the diagnostic workup needs to consider several variables from congenital to genetic to anatomical, hormonal, ejaculated dysfunction, and inadequate lifestyle habits. Because of diverse range of healthcare specialists involved in this managing the male infertility, there will be a lack of cohesive treatment approach, so that either they will be untreated or they will be given an empirical treatment approach. So of this, particular concern is the lack of efficient treatment for male with idiopathic infertility. So what we already know, there are so many consensus and opinions regarding the hypogonadotropic hypogonadism, that it can be treated with exogenous hormonal treatment to stimulate the gonads and restore the spermatogenesis. But what is lacking in this is whether this hormonal therapy can be used as a potential treatment strategy to enhance the fertility in men with idiopathic oligospermia, non-obstructive azoospermia. So to address these changes and inspired by the Poseidon concept, which we are using to classify the poor ovarian responder in women, an international working group proposes a new approach to stratify the men seeking the fertility and who may be the candidates for the hormonal therapy. So how they develop this criteria? The criteria is designed by the group of experts like andrologists, reproductive urologists, and reproductive medicine specialists. The focus of this criteria is mainly on primary infertile male seeking the paternity, and who might benefit from the hormonal therapy to improve the semen quality and quantity for natural conception, who are part of ART treatment. So what is the critical drive? How can male infertile patients, mainly those with unknown causes, to explain their condition, be classified to guide therapeutic management? Second one, what is the importance of hormonal therapy and what are the current options and outcomes and limitations of hormonal therapy? So ultimate goal of this concept paper is to record patient's phenotype more precisely and to facilitate communication to the patient and also between the clinicians, to improve clinical and reproductive outcomes, to identify the areas where data are lacking in published guidelines, to encourage the research in that area and to promote the discovery of new treatment options. So clinical parameter, what are all taken in this framing this criteria, starting from clinical history, which starts from male age, what is the occupation, and his medical history, surgical history, his childhood history, and the drugs he is taking, including all other histories, and also physical and andrological examination. And semen analysis, the phenotypes are classified as either oligospermia or asthenospermia or teratospermia. These are classified based on WHO 2021 criteria. And they are also taken into account hormone concentration of FSH, LH, and serum total testosterone. As we already know, just to refresh in the basic thing, hypothalamus secretes the GnRH in a pulsatile fashion, which will stimulate the pituitary and produce the hormones FSH and LH. The LH act on the Leydig cells in the testis to produce the hormone testosterone, and also FSH acts on the Sertoli cells, which helps it stimulate the spermatogenesis. And this testosterone will act on the androgen receptor in the Sertoli cells and helps in the last stages of spermatogenesis. So the FSH mainly acts in the first step of the spermatogenesis, whereas the intratesticular testosterone acts on the last steps of the sperm maturation. The concentration of intratesticular testosterone is up to 100 times higher than the serum total testosterone. And if the testosterone, intratesticular testosterone is similar to circulating total testosterone concentrations, they are not sufficient to maintain the spermatogenesis. However, we can't measure the ITT routinely because it is very invasive. So the hormonal workup of infertility relies mainly on the assessment of FSH, LH, and total testosterone serum concentrations. And FSH also can be considered as a marker of the spermatogonial situation. which means that in presence of normal testosterone concentrations, when spermatogonia are absent or the number is reduced, the FSH concentrations typically increase. When spermatogonial number is normal, the FSH concentrations tends to be within the normal range. So they have taken normal limit of FSH in LH, FSH 1.3 to 8 international unit and LH is 1.6 to 8 international unit per liter. The most commonly used threshold for testosterone concentration is taken, which is 350 nanogram per deciliter. So coming to the criteria, with all these like hormones and semen parameter, they classify the male infertility into 5 categories. First group 1 is hypogonadotropic hypogonadism, which includes aqua and congenital causes. Group 2 is idiopathic, which is a lowered semen analysis parameters, but they are having the normal FSH and testosterone levels. Group 3 is lowered semen analysis parameters, but normal FSH with reduced testosterone levels. Group 4 is nothing but hypergonadotropic hypogonadism, where semen analysis will be low, parameters will be lower, but there will be elevated hormone levels. Group 5 is unexplained male infertility. So group 1, hypogonadotropic hypogonadism, it is characterized by the gonadal failure and reduced gonadal steroid production because of reduced gonadotropin production and stimulation. So the prevalence is 1.9% among the azoospermic cases, and among male infertility it contributes to 1.6%. So types congenital forms are anosmic hypogonadotropic hypogonadism, which is a Kallmann syndrome, and normosmic isolated hypogonadotropic hypogonadism is an idiopathic cause. Acquired causes includes use of certain drugs like anabolic steroids and this testosterone replacement therapy and all. And other causes like pituitary causes, tumors, hyperprolactinemia, trauma, or any radiation, substance abuse and all. So in this, the FSH concentrations will be below the reference range, reduced LH concentrations, and semen parameters also will be altered. So what they have suggested is treatment as therapeutic regimens vary, but typically begin with 1000 to 2500 international unit of HCG twice weekly for 8 to 12 weeks. So HCG, which is a surrogate marker of this LH, which is important for increasing the intratesticular concentrations. HCG alone appears to be able to restore the spermatogenesis, especially in adult onset hypogonadotropic hypogonadism. But in case of congenital hypogonadotropic hypogonadism or adult onset where they have found the FSH value was low, the treatment must involve administering the FSH also, like 150 to 300 international unit 2 to 3 times weekly for up to 18 months. So when comparing this HCG treatment alone to HCG and FSH combination, they will have a better therapeutic effect. So the endpoints at the end of the treatment to be measured are semen parameters and retrieval rates in case of ART, total testosterone concentrations, pregnancy rates, and quality of life. Coming to the group 2, which is an idiopathic infertility, which contributes 15 to 60% of patients undergoing infertility evaluation. In this, it includes functional hypogonadism with reduced gonadotropin action because this having the lower semen analysis parameters, but other hormones are normal. So normal serum hormone concentrations seem to be functionally insufficient to support the normal spermatogenesis independently from the ANORA underlying cause. They also suggest that there will be some kind of single nucleotide variation in the FSH receptor beta gene, so that it is not allowing the normal hormone concentrations to act properly. So suggested treatment option is FSH alone. So meta-analysis published so far in this indicates that FSH therapy in male patients with idiopathic infertility was associated with increased sperm concentration, decreased sperm DNA fragmentation, and improved pregnancy rates. This effect may be due to surplus of exogenous gonadotropin compensating for the insufficient action of endogenous gonadotropins, stimulating the weak spermatogenesis activity over the baseline levels. So in coming to non-obstructive azoospermic patients, gonadotropin therapy has also been used to stimulate the spermatogenesis in eugonadal non-NOA patients with normal FSH concentrations, and also for patients with spermatogenic maturation arrest, but this requires a further study. What is the rationale behind giving the FSH hormonal therapy to this spermatogenic maturation arrest is The exogenous gonadotropins might be able to maximally stimulate the clones of good spermatogonia that are capable of successfully surpassing the arrest points. So, goal of this therapy is to induce the recovery of sperm in the ejaculate or improve the surgical sperm retrieval rates with medically assisted reproduction. So, there is one study done by Steves and colleagues in 2023. Couples with male partners exhibiting idiopathic oligospermia who received gonadotropin therapy had significantly higher natural or assisted reproductive pregnancy rates compared to those who did not receive the therapy. On average, what they found out is 7 patients with idiopathic oligospermia need to be treated with gonadotropins to achieve one successful additional pregnancy. So in this idiopathic infertility group, the endpoints to be measured after the treatment is 7 parameters, DNA fragmentation rates, quality of life, and pregnancy rates. So coming to the group 3, it is just a variation of group 2. Prevalence is around 20% of all idiopathic infertility males. Comprises patients with altered sub-analysis parameters, normal FSH, but low testosterone levels. So what they suggest, what might be the cause is there might be a relative reduction of gonadotropin action, may be due to single nucleotide variation in FSH receptor gene, or polymorphism also might be the cause. So this group differs from the group 2 by having the reduced total testosterone activity, which is which indirectly is telling that insufficient or inefficient LH activity on the testis, and making it possible to potentially define these patients as having hypogonadotropic hypogonadism according to ICMART definition. As such, these patients may benefit from gonadotropin therapy with both FSH and LH activity, but it needs to data on this therapy are limited, so there should be some study for future studies has to be done to prove this. So intratesticular testosterone plays a crucial role in spermatogenesis. Reduced testosterone concentration might indicate reduced LH activity due to some local hindrance. So that by giving FSH and LH, we can overcome this. It should be noted that even with patients in proven genetic cause of NOA like Klinefelters, they could be also be the candidates for gonadotropin therapy because they may still have some tubules with normal spermatogenesis. But the studies on this is highly heterogeneous, so that more RCTs need to be done to prove on this. So the endpoints in this to be measured are 7 parameters: total testosterone concentration, DNA fragmentation, quality of life, and pregnancy rates. Coming to group 4, hypogonadotropic hypogonadism. Basically, there will be some cause in testis. Prevalence is up to 10%. Here, the 7 parameters are altered, but hormone levels are high, like FSH and high LH. Most patients in this group are NOA males with hypogonadotropic hypogonadism. The treatment suggested is HCG with or without FSH. So, what they told us, FSH treatment might improve DNA fragmentation and quality, but indiscriminate use also will reset the 7 parameters. So, in NOA males with hypogonadotropic hypogonadism, endogenous gonadotropins might be ineffective in adequately stimulating the Leydig cells and Sertoli cells. So what they are coming to tell us, by giving this HCG and FSH, we can promote the spermatogonian proliferation DNA synthesis in these patients, and also increases the intratesticular concentrations. But the current available evidence on this is mixed, underscoring the need for further research to elucidate the precise impact of hormonal therapy on individuals with NOA. So utilizing the Aphrodite classification could improve patient stratification for future research initiatives. So the endpoints to be measured in this are sperm parameters, testosterone concentrations, DNA fragmentation rates, quality of life, and pregnancy rates. So coming to the last category, which is a group 5 unexplained infertility, 15% of couples presenting with unexplained fertility, and in unexplained male infertility, 6 to 27%. FSH concentration, all the hormone concentrations are in normal range, and also 7 parameters also within normal range. There is no comorbidities, no known case of any history of diseases that affects the fertility, and also normal physical and laboratory test. They might benefit from stimulatory FSH to raise the concentrations above their normal baseline. So what is the basis is physiologically spermatogenesis does not run at its maximum capacity. So extra FSH might boost it further, resulting in increased quality and quantity of sperm, which could increase the pregnancy rates and reduce the time to live birth. However, owing to paucity of data, clinical trials needs to be instigated to investigate the efficacy of treatment in this group. So treatment here suggested is FSH alone. So endpoints are DNA fragmentation and pregnancy rates. So coming to the limitations of this paper, this is just an opinion paper. It needs the clinical validation also. The information about the duration of treatment and when to measure the endpoints after the treatment needs to be addressed clearly in all groups. Future aspects from the studies with regard to management of idiopathic male infertility and NOA, current guidelines predominantly state that hormonal therapy is not indicated. But this Aphrodite criteria provide evidence supporting the utility of hormonal therapy in specific groups of patients, especially in group 4, which is an hypergonadotropic hypogonadism, and also genetic cause of NOA like Klinefelters, which were well characterized in newly proposed system, and makes a call for action regarding research studies to fill the existing knowledge gaps. And Aphrodite is proposed as a basis for future trials of hormonal treatment in male infertility. Conclusion: the proposed Aphrodite criteria offer a standardized approach to classify the patients with male infertility. They can improve the communication and clinical management among the clinicians. Furthermore, they may highlight areas lacking the data and promote clinical research to discover new pharmacological treatment options for male infertility. Thank you.
Thank you, Dr. Kalpana.
Ma'am.
Well, I'll just say I have a few comments. This is like a concept paper, though the authors say that on the basis of Poseidon group, they are trying to put up some treatment proposals for various types of male infertility.
Yes.
Today, I mean, we are cutting across such extremes. Like today, somebody may say, why treat any male infertility at all when I just need one sperm and do an ICSI and give a pregnancy? And to the other extreme, like this paper proposes almost hormone treatment for all types of male infertility. Whereas we know it is only hypo, which is classically we are trying. Maybe the unexplained where we don't have, again, we don't have any reason for unexplained infertility being treated with hormones in male factor, because it's not comparable to the female type where we are trying to increase the number of oocytes or something. Here, again, it remains an empirical one. To offer gonadotropin therapy for hypergonadotropic hypogonadism is something which people will not easily accept it. And moreover, if you see the cross references, some of it, of course, we could see, most of these have come out with few number of patients with very short follow-up, so much so that people have just given it and done one semen analysis before and one after 3 months or so. And that's all. And then they say it can improve. Where we say today maturation arrest or Klinefelter, every patient in genetic abnormality can also have some functioning tubules. The concept again is you give supra-threshold hormone levels so that you can be better in a surgical retrieval specimen. Not in those to get really semen parameters improved, but surgically if you want to try, you may be able to succeed. Again, everything is based on very, very handful number of patients and short follow-up. And I would also put one more criticism, like if I'm doing a large study or I'm putting up a proposal, this is more of a proposal, I would like to look at small studies or short-term follow-up, which are more favorable as compared, I mean, in relation to my question. Whereas the authors, if you look at the literature, there are n number of studies which say there is no difference in the parameters. The treatment is not really indicated or not really effective, but still many people give hormones for all except definitely the hypergonadotrophic type. So it is still a thing which is opened a Pandora's box. Or if you want to just say any male infertility who comes NOA or azoospermia, everybody you start giving gonadotropins and reassess. The paper almost amounts to that. Of course, this is only a concept. It's for us to take clinicians to take it forward, whether I can randomize it. Do I have the time factor or something? How far it will take clinicians to give effective pregnancy rates, it's to be seen. Because again, we come to just 1 or 2 sperms, let me do an ICSI, and which is more or less a proven. Even with, they say, okay, the type 2 and type 3 or type 1 also, the concept, the paper says you improve the semen parameters. Type 1 is definitely hypo, it's very good. Even for that, the recommendation is once you see improvement, you freeze the sperms, sperm banking, you put it into the freeze so that you can be utilized. That is because for endlessly, people may not be ready to take the treatment even for hypo. So if you get the semen parameters improvement in the first category, you put it in the sperm bank. And I can just invite Dr. Nandita or anybody's this thing.
Ma'am, Dr. Sharath here, can I make a few comments, ma'am?
Please.
Yeah. Ma'am, I really appreciate your comments, ma'am. They are quite informative. But especially in cases of hypergonadotropic hypogonadism, the basis which they explain is because what we are measuring is the immunologically active gonadotropins, ma'am, in the blood, whereas this biologically active hormones which we are giving may have an effect on the spermatogenesis. Now, that is the explanation they have given. And second point I wanted to say, I want to check with Kalpana whether this oral medications like clomiphene citrate or anastrozole, they didn't mention anything about it, ma'am. Whether what is their role in the management of male infertility? I wondered.
Sir, they have just made a one point that in cases where the testosterone estradiol ratio is reversed like in obesity, where there will be excessive peripheral conversion or aromatization of testosterone to estradiol, they will play a role like giving letrozole. It may improve the testosterone estradiol ratio and all.
What about clomiphene citrate, Dr. Kalpana?
Clomiphene citrate also we can use to improve these gonadotropins, increase the gonadotropins action so that it can increase the spermatogenesis also.
Okay. Thank you, sir. It's really good, Dr. Kalpana. Quite interesting and quite latest, no? Yeah, we all really benefited by your presentation. Thank you so much. Thank you.
There was few case reports by Dr. Ramaswamy, Ranjit Ramaswamy, regarding the letrozole and Klinefelters. I think he has tried, and then that was very few cases done by him, I think, and he found there are sperm counts using a letrozole in Klinefelter's patients.
Can I add a comment?
Yes, Nandita.
Okay. See, in that group 3 and 4, where they say the FSH is slightly higher or it's hyper, but sometimes you have a normal testis, though it is higher. So in those patients, I had run a FSH polymorphism test, which was available, and we gave gonadotropins because it will say it will respond to FSH therapy or whatever it is. I did try for at least 3 months. They took at least they took it bi-weekly or something. It did show an improvement. So when there is absolutely very less sperm, and you see something like 100 sperms and all that, it's like for us, oh wow factor, because we are able to get some sperm coming out. So I think that is got a role. It's not been explored much in our population. Probably we can look at it as a treatment. Now a lot of talk is there even on anastrozole in this particular group, where the testosterone is low. So I have used anastrozole also. It has been quite effective, but I don't have the numbers to speak on this podium at this point of time. But over time, probably we'll do a review. We have seen at least improvement in about 30 to 40% of the patients.
Is a role of testing estradiol values in these patients when you have a testosterone estradiol ratio?
See, that is what now the company is promoting. Yeah. But initially, when the testosterone was low and you have something like your FSH is just pushing, so you're looking at peripheral aromatization to work to help to improve the testosterone levels also, or push it up. So it's the mechanism. We all use CC at one particular time. All of us, I think, Dr. Sharath will remember. Invariably, we used to write 25 milligrams of clomiphene till it went down the over the decades. Now we spoke about tamoxifen, we spoke about even letrozole is being given, anastrozole is being given, but we don't have any major RCT to comment on that. And probably this group, like the Poseidon group, probably if we evaluate this whole process, we might be, in a better situation to discuss. It is still a very preliminary baby, analysis they have done. If they have opened a window, probably we need to look through it.
Yeah, it's just a food for thought. Food for thought.
Yes.
In fact, there is one small study. There's just studied about 12 patients where they did one cycle of surgical sperm retrieval and compared with the second surgical sperm retrieval after 3 months of gonadotrophins. And they found a marginal improvement, even when the gonadotrophins were marginally high. So it's just a food for thought. I think we clinicians have to take, and whatever we do, it will be like a pilot study. You can't have a large number. You can't have an ethical approval very easily coming forth, especially when I want to give gonadotrophins in a hypergonadotrophic patient. So things will move as small pilot projects with multicentric, multiple centers to gather some evidence. So that will be, maybe we'll see the light of the day, maybe 5 to 10 years down the line.
Another thing also, talking about the total testosterone versus free testosterone and then intratesticular, people talk about the 17-OHP would be a better test for testing the intratesticular rather than a total testosterone. So again, and the values are not probably proper, a cutoff has not been given with the 17-OHPs. Where we have done, where they found that it did not have any effect on the semen parameters, but men with sexual dysfunction had a lower 17-OHPs. It was a very small pilot study, but I think the Ramchandra team has done a study on 17-OHP. So I'm sure if Radha is there, she can throw a light on that.
What is the cutoff point you take for 17-hydroxyprogesterone?
So there's some values they give us, the lab values, but there is no proper cutoff as such, like 0.5 to 1 or something like that. So each lab has got different values. So there is no proper cutoff.
Okay.
Rather, I don't know if Ramchandra is doing the test because we send it outside.
Yeah. Dr. Radha is there? I think so.
So our own small study found that it is only to do with the sexual dysfunction, not with the semen parameter.
Thank you.
But sometimes even if you see a high FSH, sometimes they tend to have some few sperms as well. So you cannot just say they have got a high FSH and, you can, I think we found few sperms when there is a normal size testis.
With the non-obstructive azoospermias, no?
Yes,
Always.
sir. When the FSH is anything above 7, 8, then we talk about, elevated levels. Even if they are 12, 15, we have found sperms there.
Yes, I do agree.
Even in Sertoli cell only syndrome, they say you can get testicular sperms, and what we said maybe a decade ago, that this is untreatable, there is no treatment. We do have some solution. Maybe with this categorization and use of hormones, we may have better answers.
No, I think with the non-obstructive people go ahead with the microtesia and they find definitely some sperm tubules are seen. So they just don't shut the door with saying that no.
Correct, yeah.
Yes, ma'am, we move on to the next.
Okay. I think next we have our chairperson, Dr. Ramesh Raja. Is diploma in clinical embryology, fellow clinical andrology, sexual medicine, and PhD in embryology. He is pursuing that. He's a senior clinical embryologist, andrologist with 15 years of experience, and executive member of TAPISAR, IMA State Council member, Society of Embryologists, ISAR Award. He's got a lot of credentials to his credit, and the first Indian to receive proficiency in ICSI issued by MCOL. That's a very creditable achievement. Published papers in national and international journals, and area of interest is quality control in IVF and lab and sperm DNA fragmentation. Welcome, Dr. Raja. We'll have your expert input in the next presentation, which is lab oriented or embryology related also.
Vanakkam, ma'am. Thank you so much for the kind introduction.
Shall I
Ramesh sir, can
call
you-
the next?
Okay.
The next presenter is Dr. Sadhvi Balaji, who has done her MBBS from Government IIT Perundurai Medical College. She is DNB Ops Gynae from Coimbatore. She is pursuing a second year of FNB Reproductive Medicine at Women's Center by Motherhood, Coimbatore. Over to you, Dr. Sadhvi. You can start sharing your slides.
Good evening, all. Actually, I'm facing an issue with my lap, I guess, ma'am. Like, suddenly it's turned off. Can I just join from my mobile?
Whichever way, if you can share your slides, that's
Will you
perfectly
be able to
fine.
share your slides, or do you want to send it to me? We can share it for you.
Yes, ma'am. I'll do that, ma'am. That would be better, I guess. Like, suddenly I just logged out. I don't know what happened.
Please share
Just
it now. Please share
Yes,
it.
ma'am. I'm doing it now. I'm just doing it.
Or maybe I too have it, I think. Should I?
Ma'am, I'm just sharing the slides, ma'am.
Okay. Okay.
Sindhuja, ma'am, I've just shared it with you.
Yeah, I'm just sending it to the. Sahiti, have you received it?
Yes,
Uh,
ma'am.
Will you be able to share now?
Yes, ma'am. I'll download. Just give me a second.
Yes.
Ma'am, shall I start?
Yes, please.
Good evening. So today I would be presenting the topic. Ma'am, next slide, please. Clinical outcomes of ART in predicted hyperresponders, in vitro maturation of oocytes versus the conventional ovarian stimulation for IVF or ICSI. This is from the journal Human Reproduction, Jan 2024 edition. Next slide, please, ma'am. The impact factor of this journal is 6.1. Next slide. The study question for the day is: do ongoing pregnancy rates differ in predicted hyperresponders undergoing ART after the IVM of oocytes when compared with conventional ovarian stimulation for IVF or ICSI? So before going into the question, I would like to give a little introduction about the topic. In ART cycles, women with increased functional ovarian reserve exhibit ovarian hyperresponse to gonadotropins. Hyperresponse could lead to complications such as the ovarian hyperstimulation syndrome or the ovarian torsion. To avoid these complications, many mitigation strategies have been developed, such as the antagonist protocol, the GnRH agonist trigger, freeze-all approach, and also the use of GnRH antagonist or cabergoline post-ovum retrieval. In vitro maturation is a process in which immature cumulus oocyte complexes are collected from the antral follicles, and this has been cultured in vitro to M2, and then this has been suggested as an alternative treatment in predicted hyperresponders. So this diagram just explains the difference between a conventional IVF and an IVM cycle. In case of a conventional ovarian stimulation, we give in gonadotropins, and once the follicles reach the pre-ovulatory stage, then a trigger is given, and post-trigger, usually after 36 hours of trigger, the pickup is done, and this oocyte is then followed by IVF or ICSI. In case of an in vitro maturation, so here minimal or no stimulation is done, and the ovum pickup is done only like at the small antral stage itself once the follicle reaches around 10 to 12 of size. And this immature follicle is allowed to mature in vitro, and once it reaches a mature stage, this is then followed up with IVF. ICSI. Next slide. So these are the current IVM protocols which are in place. First is the standard IVM, in which there is minimal or no stimulation, and the pickup is done once the follicle reaches around 10 to 12 of size, and then allowed to culture in the IVM media in vitro. And once it reaches M2, this is followed up by ICSI. The second is the pre-IVM or the biphasic IVM, in which there is a minimal or mild stimulation, And the pickup is done once the follicle reaches around 10 mm. And there are two medias in this. One is the pre-IVM medium, wherein the oocytes, usually in the GV stage, remains in the GV stage and allowed to, the meiotic arrest is maintained for some time, usually around 24 hours. And then it is then transferred to the IVM media, wherein the meiotic resumption occurs and the GV is converted to M2. And this oocyte is then followed up with ICSI. And then there is the truncated IVF, wherein we give a minimal stimulation, and once the follicle reaches around 10 to 12 mm of size, a HCG trigger is given, and this immature oocyte is then allowed to culture in vitro, and then we go in with the ICSI. And finally is the rescue IVM, which we usually see, wherein the conventional stimulation like thing occurs, and like once the follicle reaches around 18 to 20 mm of size, the pickup is done, and once we see that it's still immature, we allow it to mature in an IVM culture media, and once it reaches the mature state, this is followed up by ICSI. Next slide, ma'am. So this slide explains the current spectrum of IVM in clinical practice. The concept came in 1960s, and in 1991 we had the first IVM baby, and then at around 2000s we came up with the concept of biphasic IVM, wherein the synchrony between the nuclear and the cytoplasmic maturation came about, and we could overcome that. And then in 2010s we started talking about IVM in case of oncofertility as well as fertility preservation as well. And now the present topic of discussion is about the epigenetics and the detailed the follow-up study of IVM babies. Next slide, ma'am. So why to go in for IVM when we already have a conventional stimulation protocol? The advantages are the less hormones, lower cost, lower risk of OHSs, shorter treatment, less discomfort, higher patient satisfaction, less treatment monitoring in terms of scans, and less cancellation rates. And looking at the disadvantages, it has a lower maturation rates, low developmental potentials, modest pregnancy rates, higher early pregnancy loss, protocol inconsistencies, complex lab logistics, and also the long-term data are still unavailable, and it also has a lower credibility. Next, ma'am. Yeah. So IVM has recently been declared non-experimental by the ASRM. Many babies are born out of IVM since the first one in 1991. We have around 400 plus as per records. And published data lacks the persuasiveness as it mixes the rescue IVM, that is maturing the immature oocytes retrieved from the conventional ovarian stimulation, and a standard IVM which differs in the oocyte competence. It is also unclear whether the difference in the efficiency between the IVM and the conventional ovarian stimulation may vary depending on the extent of the functional ovarian reserve. This analysis, this study analyzes the efficacy of the IVM in predicted hyperresponders depending on the different serum AMH cutoff levels when compared to the conventional ovarian stimulation. Next slide, ma'am. So the study design, this is a single center retrospective cohort study in which the highly purified HMG primed non-HCG triggered IVM cycles were compared with the conventional ovarian stimulation with gonadotropins in a GnRH antagonist protocol in a predicted hyperresponder. This was conducted in a tertiary referral university hospital at Belgium between Jan 2016 and June 2022. Next, ma'am. Yeah, the inclusion criteria which was taken for the study was age between 18 to 36 years, women with PCOM who were eligible for the ART, such as failed ovulation induction, male factor or tubal factor, and the first IVM or ovarian stimulation cycle was only considered, and the AMH had to be above 3.25, and PCOS phenotypes A, C, and D were only included, which was classified according to the Rotterdam's criteria. Exclusion criteria: patients requesting PGT or fertility preservations, partner sperms extracted using the testicular sperm extraction, as well as the PCOS B phenotype. So as I already told, it's a retrospective single center study. The first cycle was taken into consideration. In the IVM cycles, we had around 463 cycles which were performed. In all these cycles, the pre-treatment was combined oral contraceptive pills for 14 to 21 days. And this was followed up by 150 to 225 international units of HMG injections, which was started on day 3 or day 5 for 3 days. No trigger was given, and retrieval was done 42 hours post the last HMG injection. And in case of the conventional ovarian stimulation group, The standard recombinant FSH or the HMG injections were used, and the starting dose was decided by the physician. GnRH antagonist protocol was used, and the trigger was either the urinary HCG, recombinant HCG, or agonist trigger, that is triptorelin, and OPU was done 36 hours post-trigger. All the oocyte retrieval procedures were performed using a 17-gauge single human needle. So the lab procedure, the follicles were aspirated using the human tubular fluid supplemented with heparin 5000 international units per ml. Follicular aspirates were filtered through the cell strainer, and the cumulus oocyte complexes were washed and transferred to a 4-well dish. The media which was used for IBM was 75 milli international units per ml of HMG plus 100 milli international units per ml of HCG plus 10 milligram per ml of human albumin substrate. And oocytes were cultured in groups of 10 per well in 500 microliter of IBM media for 28 to 40 hours at 37 degrees Celsius with 20% oxygen. Oil overlay was done and only ICSI was performed in case of an IBM. The outcomes. Primary was the cumulative ongoing pregnancy rate, which was defined as the clinical pregnancy with the presence of heartbeat at 10 weeks of gestation. The secondary outcomes which were considered were the time to pregnancy, which was calculated by the number of embryo transfer cycles until the ongoing pregnancy was achieved. And next one was the cumulative live birth rate, that is the percentage of deliveries with at least one live birth resulting from an initiated ART cycle, including all cycles in which fresh or frozen embryos were transferred until one delivery of a live birth occurred or until all the embryos were used. And finally, the OHSS rate was also calculated. Next, ma'am. So this was the embryo culture technique and the transfer which was used. In the IBM group, only ICSI was done. In the conventional group, either IVF or ICSI was done, like at the discretion of the physician. And in case of a poor sperm quality, that is sperm concentration less than 15 million per ml, in those cases, even in the conventional ovarian stimulation group, only ICSI was performed. Fertilization was assessed 16 to 18 hours post-insemination by the presence of 2 pronuclei. On day 3, the embryo was evaluated for the number and symmetry of the blastomeres and percentage of fragmentation, vacuolation, granulation, as well as the multinucleation. The day 5 blastocyst was scored according to the grading system by the Gardner and Schoolcraft, and the embryo quality was assigned as A, B, C, or D by a predefined algorithm, that is excellent, good, moderate, or poor. And the embryo grading was performed in the same way for all the embryos derived by both the in vitro as well as the in vivo matured oocytes by 10 highly trained embryologists, by a team of 10 highly trained embryologists, and fresh ET either day 3 or day 5 after ICSI with the vitrification of further, surplus embryos was done. In case of freeze-all cycles, that is in cycles in which there was no fresh embryo transfers, all the morphologically good embryos were vitrified either on day 3 or day 5 after the ICSI. And the endometrial preparation in this case was done with oral estradiol valerate or transdermal estradiol with vaginal micronized progesterone. Next, ma'am. Yeah, statistical analysis was done based on standard statistical test, and all the data was calculated using the Stata 13 software. Next, please. Next, ma'am. The results. So the patient characteristics, when we compare the IBM versus the conventional ovarian stimulation, patients in the IBM group were younger, had a higher BMI, and had a significantly higher AMH and higher total and free testosterone levels. And also the PCOS phenotype A was higher. That is, the more severe form of PCOS was pushed to the IBM group and also had better sperm parameters. Next, ma'am. So this chart shows the baseline patient characteristics of both the IBM and the conventional group. As we already saw, the IBM group were younger and they had a lower BMI when compared to the conventional ovarian stimulation group. Next, ma'am. The cycle characteristics, when we look at it, the IBM cycles yielded more cumulus oocyte complexes. However, the number of M2 were comparable in both the groups, and also the embryo utilization rates were significantly lower in the IBM group. This chart shows us that though the cumulus oocyte complexes were higher in the IBM group, the M2 was comparable between both the groups, and also the utilization rates were better in the conventional ovarian stimulation group. Also looking at this table, we know that the OHS's risk was none among the IVM group, whereas the ovarian stimulation group had around 12 cases of OHSS was reported in that conventional ovarian stimulation. Next slide, please, ma'am. Yeah, looking at the reproductive outcomes, the conventional ovarian stimulation cycles more often resulted in an ongoing pregnancy compared to the IVM cycle. The cumulative ongoing pregnancy rates after IVM and the conventional ovarian stimulation converged with an increasing serum AMH levels. However, the cumulative ongoing pregnancy rates remain stable up to a serum AMH level of 12 nanograms per ml in women who had a conventional ovarian stimulation. The efficiency gap between the IVM and the conventional ovarian stimulation was less than 10% in women with serum AMH levels of more than 10 nanograms per ml. Thanks, ma'am. So this chart shows how the convergence occurred. So at around 10, both of them start converging and the outcomes remain stable up to 12 nanograms per ml of AMH, and then it converges further. Next slide, please, ma'am. So the IVM group more frequently had a transfer of cleavage stage embryo when compared to patients with the conventional ovarian stimulation. However, in both groups, the ongoing pregnancy rates was mostly achieved following a vitrified warmed ET rather than a fresh ET. The time to pregnancy was comparable between both the groups. So this shows that around, yes, okay. So it's okay, ma'am. Next slide, please, ma'am. So as I told, no OHSS was found in the IVM group, whereas we had 12 cases of OHSS in the ovarian stimulation group. The cumulative live birth rate was significantly lower in the IVM group compared to the conventional ovarian stimulation. In women with serum AMH level of greater than 10 nanogram per ml, a small difference in the cumulative live birth rate was observed after IVM after IVM and the conventional ovarian stimulation. The type of ART, the age, the free testosterone level, and the number of cumulus oocyte complexes was significantly affected the cumulative ongoing pregnancy rate. The efficiency graph between the IVM and the conventional ovarian stimulation in terms of cumulative ongoing pregnancy rate was less than 10% in women with serum AMH greater than 10 nanograms per ml. Next, please, ma'am. However, in case of hyperresponders with serum AMH levels greater than 10 nanogram per ml, only the number of cumulus oocyte complexes and the free testosterone levels were the only parameters predicting the cumulative ongoing pregnancy rates. Next, please, ma'am. Yeah, so for the discussion, the objective part of this study was to evaluate the size of the efficiency gap between the IVM and the conventional ovarian stimulation, followed by the IVF in predicted hyperresponders across a range of serum AMH cutoff levels. Cumulative ongoing pregnancy rates per started ART cycle was lower in the hyperresponders after IVM when compared to the conventional ovarian stimulation in general, but there was a trend towards higher cumulative ongoing pregnancy rates after IVM, with increasing serum AMH levels of the patient. This correlation between serum AMH levels and cumulative pregnancy rates was not observed in hyperresponders who had ovarian stimulation. So cumulative ongoing pregnancy rates after IVM and conventional ovarian stimulation converged as the AMH increased. In patients with AMH more than 10 may represent the most suitable target population for IVM. Next, please, ma'am. 1.5% risk of OHSS after the conventional ovarian stimulation in this study is rather high, and this may not reflect the actual risk of moderate to severe OHSS in case of a freeze-all approach. Actually, the occurrence is less than 1% in case of a frozen cycle. Data from this study supports previous findings showing that the cumulative outcomes correlate with the number of oocytes collected in conventional ART as well as in case of the IVM cycles. This study emphasizes the importance of proper patient selection for IVM treatment and may explain why the conventional ovarian stimulation has consistently outperformed IVM in previous comparative studies when unselected hyperresponders were recruited. Although they observed a higher likelihood of cumulative ongoing pregnancy rates after IVM in women with higher AMH compared to the women with lower AMH, the higher cumulative ongoing pregnancy rates in these patients were not usually caused by the higher AMH per se, but by the potential of these women to yield higher number of cumulus oocyte complexes, as shown by multivariable regression analysis. In countries with high out-of-pocket cost for the patient, like in India, the uptake of IVM as a mild approach ART will likely be low unless IVM becomes more efficient as compared to the conventional ovarian stimulation. When introducing IVM in the fertility clinic, the physicians and the lab staff may be subjected to a learning curve, and there may be a relation between the clinic's volume of IVM cycles and their success rates. So the strengths of the study, this is the first study to correlate the extent of excess ovarian functional reserve with the clinical outcomes after standard ART and IVM, and to identify the patient population who may achieve the highest pregnancy rates when they embark on IVM treatment. The present study also suggests a valuable role of serum AMH as the tool to select patients who are most suitable for the IVM treatment. Next slide, please, ma'am. Limitations of this study. First of all, this is a retrospective design. And in this study, 58 out of the 463 patients donated an average of around 9.4 cumulus-oocyte complexes for their research in their first IVM cycle, which may have mitigated their chances of pregnancy from that cycle. Several patients in both the groups had traveled from abroad for fertility treatment to their clinic and went back to their country once they achieved an ongoing pregnancy rate. So they were lost for follow-up. Patients with a severe PCOS phenotype and very high levels of AMH are relatively underrepresented in the conventional ovarian stimulation group because they were most frequently counseled for the IVM by the physicians. Thus, the results are less robust in the upper range of serum AMH spectrum. Next, please, ma'am. So the conclusion, IVM as a process entails a learning curve that shouldn't intimidate, but rather be embraced with confidence. The research should focus on improving IVM for better outcome. Prospective trials needed for conclusive evidence. Prospective trials are needed for conclusive evidence, especially in case of severe PCOS. Thank you.
Thank you, Sadhvi.
Thank you, ma'am.
For a detailed presentation. Just a few comments. Being a retrospective study, it has got all the flaws of a retrospective study. There are too many potential confounders. In fact, if you see of all the cycles, only 27% was IVM and 73% were ovarian stimulation. And as you already said, the PCOS severe type, 93% in the IVM group. Whereas in the ovarian stimulation group, only 44% were PCOS. There were other causes of hyperresponders. Since they chose to select only AMH as a cutoff and not on the morphology, to me, I feel even category B could have been included because if the AMH was high and anovulation and hyperandrogenism, they could have also been included. Of course, it's a retrospective study. Something they talk about 10 embryologists reviewing each embryo and scoring. How they managed to do that in a retrospective study is subject to many questions. Whether they had the photographs to be reviewed by everybody, it's anybody's guess. Because in the normal course of clinical treatment, you may have 1 or 2 embryologists, concurrence maximum 3. But to have 10 embryologists scoring every embryo is a little beyond comprehension. And they've also said freeze all in some cases, some fresh transfer. There's a lot of variable in everything. Despite all this multivariate regression analysis, they do say beyond 10, it is better in IVM. And if you just look at the last table, of course, which you projected, and in the IVM group, the number of patients who had more than 10 were nanogram AMH was 48%, as compared to just 3.8% in the ovarian stimulation. So the weightage was more on the IVM side for all heavy PCOS types, high AMH. The mean AMH in the IVM was almost 11 as compared to just 5.3. So it has got all the problems which happens with a retrospective study. But then, yes, there is a definite take-home message that if it is more than 10 in this study, in fact, we have a Vietnam study, we have a China study where they have got cutoff of 7.5, 8.5. They said that beyond that, IVM is comparable, definitely, because the dropout rates will be much higher with OHSs. So that is the take-home message. Maybe every center or every country have to have their own studies to say, first of all, yes, IVM has to become a, either we should have a nationalized one central place or a couple of central places where IVM is done, because it's not easy to start IVM in every center to have comparable results. May I have Dr. Ramesh to your
Yeah.
comments?
Dr. Ramesh,
Yes, sir. I'm here, sir.
good evening. Can I ask you some layman's questions for you?
Definitely, sir.
Ramesh, this one, last 15 years, no, we are talking about IVM, no? So is it really took off from the time? Because Dr. Murthy, no, who was worked with me as an embryologist, he did a lot of work on IVM, no? But even now, no, we are the same, that basic level only, no? That's one thing. And second thing, you know, with these antagonist cycles with agonist triggers, almost we brought ovarian hyperstimulation to the zero level, no? So even that particular scenario, we have any place for IVM. And second thing, third one, everyone doesn't have an expert embryologist, Dr. Ramesh, no, and they too don't have an standalone lab, no, IVF lab as Ramesh has, no. So what is the role of IVM for a general infertility practitioner or a general IVF clinics, no? So these are my basic questions, no. So.
Started in 2009, sir. Till 2015 and 16, we have been trying with IVM with very few patients, sir. After,
Yes.
I think, 17, 18, 19, the single human came up and it was like a boom, sir. So people started using, they could able to retrieve everything. This paper actually I can see is the protocol is actually the variable things. So they didn't mention properly about the protocol first thing. Second thing is it's very difficult to identify the IVM oocytes. It won't come with the cumulus complex. It usually comes with the granulosa. We need to at least screen 2-3 times to find out the oocyte. It will be very difficult, sir. Initially, we have tried our own media with, adding the FSH with the animal oocytes, and we found that there is a little, because it was very difficult for us to get the IBM media. Later in 2012, we can able to get the media from the Mumbai, sir, through these companies. After that, suddenly what has happened is from 2017-18, they have stopped using the media. It was very difficult, and people also started that controlled ovarian stimulation was really under control, sir, actually. But after this COVID, I don't think so. We are using IVM at all. But this post culture, suppose after retrieving there are few GB or M1, we are culturing the same culture media which has been used for the embryos for the culturing. But we have found that M1 has been changed to M2. We have injected, embryo development was good, and we transferred, we got pregnancies even with the M1. But GB,
even GBs also, no, sometimes they're maturing into M2s, no? My embryologist says that one. I don't know.
the numbers are very less from.
Yes, right.
But yeah, even one patient, we got all the oocytes for M1, sir, actually. Around 12 oocytes for M1. We did XC at 24 hours later, sir. We could able to find get around 8 M2. The patient was luckily positive, sir, actually. This is go on the IVM, sir.
Thank you.
The Bangalore Dr. Gunashila team, they're doing a lot of IVM, sir.
IVM.
Yeah, Dr. Devika Gunashila.
Okay.
They're doing a lot of IVM, and I think they've published a lot of babies also born.
But it's after COVID, I don't think so. People are doing this IVM.
IVM, okay. Any reason for that after COVID?
I think the stimulation has been come under the control. The response is also very less, I guess.
There are two ways, no? There are certain people will give you the injections, FSH, and then HCG, and then do it. Certain people will take it directly and then go ahead with the.
Usually, we have HCG minimal and we are taken it up. But it will be very difficult to find out the oocytes actually.
Of course, more common would be at least for the beginning centers, a rescue kind of IVM. You know, that's more often that's what people start with. But this paper says you electively plan IVM beyond AMH of certain cutoff.
Maybe there are
Probably
certain
does it-
patients who take a longer time for a stimulation, the PCOS that are hyperandrogens. Maybe such patients we can just go ahead, trigger with HCG and go with an IVM or something. You will be thinking that the estrogen will be going up and then the follicles will be slowly growing. So I think maybe such patients we could think of.
Probably
different.
Yes,
it
Radha.
may be having a role. It may be having a role in places where they are doing fertility preservation. Probably in those cases it has a role. And I just wanted to add, even in our the institute, we just keep some of those immature oocytes. We keep them for culturing for a day and then see. Some of them, they do grow to M2, and after that also they have done HC. But we have not done in detailed analysis. So whether in that way, whether we can do initially, if not, we are not doing IVM totally.
Yeah, I've seen M1 converting into M2s.
Even
GVs
GVs at times.
rarely, yeah.
GVs also, if we can keep them for a culture for a day after 24 hours, whether we can see whether they're growing and then can we inject and see if anyone is trying like that.
Yeah. Sometimes,
Actually, when the percentage is very high, ma'am, I think many people try it actually.
Yeah.
But the mainly why it is not being successful is because, like we are seeing now, ma'am, like in PCO cycles, we have to take them when they're about 10 millimeter or 12 millimeter and retrieve it when they're all as a cohort of GV and give them the ideal environment to basically, so what we are looking at is only the nuclear maturation. Actually, the cytoplasmic maturation is the one that takes more than 24 hours actually. So based on that concept, only this kappa, AVM and all those things were coming up in a big way because they said first we have to arrest the GV for some time to allow for the cytoplasmic maturation to happen. And then after that, when it becomes an M2, then the embryo quality, euploidy, all that is better. But in a stimulated cycle, when we are waiting for these GVs, if they're really from small follicles, okay. But if they're actually coming from big follicles, then it means that there is some sort of a developmental thing in that. That's why all the GVs that we culture don't become M2 actually in stimulated cycles.
Dr. Kundavi?
Yes, sir.
I want, because Dr. Radha is there, I would like to know about that 17 alpha hydroxyprogesterone.
What is your cutoff, Radha? Because you all also did after
Sorry.
that only we also started.
A little more in detail.
Actually, we started after we saw Dr. Ranjit Ramaswamy's paper and our PGs went there to Miami. So I think his cutoff was different and what we got was entirely different. But now still we are doing it as an ongoing study. A small cohort, what we did, I think the cutoff was 1.49, which was not correct. So we thought we will continue. Probably after a few months, probably we will analyze and see. We have started again collecting the data. Initially, we did 17-hydroxyprogesterone and then gave them medical management for 3 months and repeated in those patients. So we found there was a significant increase in the levels and also the improvement in the medical line of management in oligosospermia, those sort of patients. But our cutoff value of 1.49 was not matching with Dr. Ranjit Ramaswamy's. So we are continuing it again.
No, what is the
Indian lab? The Indian lab gives a wide range, like 0.4 to 0.5 to 1.4 or something. So we really do not know the exact cutoff value, sir.
No, what is the basis of estimating 17 alpha hydroxyprogesterone?
So that is an indirect markers actually, because we are not measuring it may not correlate with the serum testosterone and the intratesticular testosterone. So it's one of the indirect marker. So we can measure 17 OHPs in these patients. And the cutoff value, they say whether your line of management, medical line of management, they respond to or not, or you can counsel them directly to go for HC. So that helps in taking a decision. That is what that study says.
No, what is the scientific basis I wanted to know? 17 alpha hydroxyprogesterone.
That's what she says. No, so it's a medical management. It helps you whether, helps you to decide whether the patients would respond for a medical management. Ideally, it shows the intratesticular testosterone levels, not the total testosterone.
Yeah, not the total. So based on one particular cutoff value, beyond which you can say that this patient will respond to medical line of management or not. There's no point wasting the time, 3 months of medical management and then see. Probably once we analyze our results, we are ongoing study is going on. So once we analyze, I think we should be able to publish.
Thank you. Thank you.
Thank you, sir.
Dr. Kundavi,
Yes, sir.
any more questions?
Yeah.
There are
Yes.
two from chat box now actually. One, they were asked about the success rate of rescue IVM.
What's a special media and which should be used? They're talking about the embryo quality with the M1 to M2. Yes, sir, Ramesh.
First thing is the success rate of rescue IVM is actually after taking up the thing. I personally, it was like initially it was very good. We could able to get the good grade embryos of around 40%. So now we stopped using this IVM. We don't use it, but we don't use any special media for IVM. We actually culture with the normal culture media for the embryos to culture because there is no availability of IVM media per se in that. Now in the market, it's very difficult to get the IVM media. Even if you order the IVM media, it is not up to the point actually. One thing. Second thing is from the embryo quality of M1 to ICSI was very good actually. One patient we got around 12 oocytes, all the oocytes were M1. And then next day after 24 hours, 8 oocytes has been changed to M2, and we could able to get around 6 of grade 1 embryos on day 3. We frozen on day 3, we transferred, and the patient was positive on the first thing, and there were 2 sacs available, present, and the patient has been delivered also, twins.
Ramesh, can I ask you one question? Like, if you're planning for a rescue ICSI or something, already you have done an ICSI, right?
Yes, ma'am.
You inject another sperm there?
Actually, rescue ICSI, I stopped using after this 2018 because it was very difficult to find out the sperm whether it is activated or not. Sometimes when you started injecting, you'll be finding 3 PMs on the next day. So there was a study like if you are able to identify a bigger polar body, we need to, exclude it. We need to aspirate the bigger polar body and leave it for the embryo growth. But it was like we don't know, ma'am, really. So we stopped using that, ma'am.
So for that, would you use a semen sample which has been kept for another 24 hours, or you ask for another sample to the family, to the husband again?
One thing is, if you have a backup sample frozen, you can use it because keeping the sample for 24 hours, life will be there. But people say there will be ROS production will be there because of the dead sperms. We usually do with the backup semen, actually.
So you mean to say for all patients, you have a backup sample rather than the sample which is used for ICSI?
Yes, ma'am. Definitely, we'll have it, ma'am. So wherever I go, I usually get the backup semen sample for all the patients. So once the patient has been done, we'll discard the semen sample, informing the patient also, ma'am.
Okay. Yes, Dr. Radha can give the vote of thanks.
And one thing is, if we have a doubt and we are planning to do ICSI later, the fresh sample, what he has given, we can freeze that again and you can use it also.
Yes, ma'am, we can freeze it. That also we can do it, ma'am. Since backup is there, we don't do it, ma'am. Otherwise, okay.
Yeah, because in our center, routinely we freeze the sample before itself. But in case we anticipate that we need to do it later, the fresh sample can be frozen and can be used again.
Definitely, we can use it.
Yeah. Okay, if there are
there's one more question in the chat box. Do retrieved M1s take 24 hours to mature into M2s? In 4 to 5 hours, we've seen maturation.
Actually, we don't require 24 hours to do it. But for this patient, actually, we could see only 1 or 2 under 6 hours. We don't check it after so many times. We usually check it at an interval of 6 hours. So I could able to find out 8 M2s at the 24 hours. So we started injecting after that.
Also, actually, if we leave it for a longer time, that is the 24 hours, I think conversion to blastocyst is higher. Rather than when we just wait for 4 hours, actually day 3 arrest is a lot in those kind of M1s actually.
True.
Last question, I think. After XQXC is done, do you transfer the same cycle?
Answering the same cycle, I think it depends upon the clinician and also how the patient has been responded. OHS are like that. Usually, FET we do. Initially, we done only FET with the rescue vaccine.
No, the endometrium might go out of phase, no?
Correct, ma'am, correct.
It might go out of phase and it may not correlate, I think so. Okay, if there are no questions, shall we conclude, ma'am, with a vote of thanks?
Yes.
Yeah, okay. I should really congratulate Kundavi Madam and Sidhuja for taking this initiative and selecting nice topics. It was really a good topic, which is very useful. And I thank the chairpersons, Dr. Nandita Thakkar and Dr. Ramesh Raja, the speakers, Dr. Kalpana and Sadri, and our expert of the day, Dr. Geeta Radhakrishnan, for sharing her the knowledge here. And I also thank the Shield for this wonderful platform. Thank you very much for all the participants and all the faculty who have enrolled today. Thank you very much. Good night to everyone.
Thank you. Thank you,
Thank
sir.
you. Thank you.
ma'am. Thank
Dr.
you, sir.
Kundavi,
Thank you,
once
sir.
again, thank you so much for the wonderful job you have done.
Thank you.
Even
Thank you,
Sindhuja,
sir.
you too, no? Thank you. Thank you,
Thank you,
both
ma'am.
of you.
Nice topic, ma'am. Actually.
Thank you, Geeta.
Thank you.
Okay, thank you.
Yeah.
Thank you.
Thank you.
The topics were chosen